Good afternoon. Welcome to the Department of Medicine Grand Rounds, COVID themed. I'm Bob Wachter. I'm chair of the department. Hopefully you know the drill by now. Put your Zoom window in full screen mode. If you have questions, type them into the Q&A box and we will try to get to them. The session will be recorded and available tonight on YouTube, and I'll tweet out the address, but there's also an address there, and closed captioning will be available. We're going to cover three distinct but interrelated topics today: the state of the pandemic, therapeutics, and emerging data on variants, with three terrific speakers, two of whom you know well. One may be new to you, although not to UCSF. If you think back several months ago, once it became clear that the variants were a problem and that we had these vaccines available, we talked a lot about a race between vaccines and variants. And we actually said that March would be the time of that race, where if we can get enough people vaccinated, we might be able to stay ahead of the variants. We'll hear from George in a few minutes about how we're doing. It appears to me as a layperson that we're doing fairly well in California, maybe overall okay in the United States, but there are parts of the country that are doing less well. And there are parts of the world, particularly much of Europe, that's doing quite poorly, where cases are actually on the uptick. On the other hand, the UK, which is the source of much of the variant that we're seeing in the United States, is also doing well. So it's kind of a confusing picture. And whenever we have a confusing picture about the state of the pandemic, we put out an emergency call to George Rutherford. George by now needs no introduction, but he's professor in our Department of Epidemiology and Biostatistics, directs our prevention and public health group, and focuses on epidemiology prevention of infectious and tropical diseases, and has been our sensei for the last year, helping to wade through the data and understand where we are. So thank you, George, for that. So George will go first. Second, we will talk about therapeutics, something we haven't talked about here for, I think, about 3 months. If you remember early on in the course of this, hard to remember a year ago, but we had almost equal discussions, maybe more discussions about treatments compared to the discussions about vaccines. And in one grand rounds that we had, maybe May or June, I asked a number of speakers sort of what's going to get us out of this mess. And there was a fair consensus that it might very well be therapeutics. It might be medicines that people would take. And if you think about the analogy to HIV, 40 years later, we don't have an effective vaccine, but we have very effective therapeutics. So it seemed time to revisit where we are with therapeutics. And for that, just as we go to George for epidemiology, we go to Annie Luetkemeyer for therapeutics. She's been helping to lead our efforts studying these agents here at UCSF and helping guide us as to which ones are ready for prime time. So I think she's going to focus mostly today on the outpatient therapeutics, particularly a whole list of orals that many people are quite excited about, but at least to my mind, seem to have limited evidence behind them. So Annie will review the evidence and help us wade through a lot of data and a lot of passion. So Annie is a professor of medicine in the Division of HIV Infectious Diseases and Global Medicine at Zuckerberg San Francisco General. She directs the clinical trials group for HIV there, and her research interest was and remains HIV and tuberculosis, but for the past year, like all of us, has shifted to COVID. So Annie, thank you for being here. The third segment will be on variants, and you'll hear some of it from probably both George and Annie, but we thought it would be a good time to do a deeper dive on where things stand with the variants, and because we're getting a lot of different news from different places. And so one of the fun things about doing these grand rounds of the past year has been a chance to reconnect with some old friends. And the old friend who we'll reconnect with is Adam Lauring, who was formerly at UCSF, now at the University of Michigan. I'll introduce him more fully when he comes on. Adam won't be joining us for about a half an hour, so let's save that till then. So let us start with George to give us a state of the pandemic and where we find ourselves today.
Thanks, Bob. Let me just dive right in. Currently in the United States, we've had more than 30 million cases. We've leveled off at somewhere around 50 to 60,000 cases per day, which is good news and bad news. The good news is it's not going up. The bad news that it's not going down. And in fact, that's a balance between some states where it's going up and some states where it's going down, and I'll highlight 2 states in a second. There have been 545,070 deaths that have been directly ascribed to COVID. Death rates are continuing to fall, but they're still at 1,500, 1,600 a day. In California, I'll touch on this more in a second. We've had more than 3.5 million cases, have most recently had fewer than 2,000 cases reported, but are averaging, if we go back up the curve, around 2,700 cases per day. And we've had 56,850 total deaths ascribed to COVID. Thankfully, that number is continuing to fall, but it's still around 200 a day, and it needs to go down substantially further before anybody's going to be satisfied. The next one, please. So in the United States, this gives you an idea by county, and you have to realize that these are divided. They're dividing the number of cases by the number of people living in the counties, which is why Mono County shows up here, and this is where Mammoth Mountain is. And that's about it. Shows up in California, but there are 2 sort of main clusters of current transmission. One is in the lower peninsula of Michigan. A lot of this is heavily concentrated around Detroit, and then up into kind of Flint and the Saginaw and the Thumb up here. And then the others in and around New York City. And I'm going to highlight Michigan and New Jersey. It's a little cleaner story in New Jersey than in New York. But if you look here, this is giving you cases per 100,000. That's how these are rank ordered. In the last 7 days, there have been 47 cases per 100,000 in New Jersey, 42 in New York, 37 in Michigan, 35 in Rhode Island, and 31 in Connecticut. So you get the idea that it's kind of clustered around here and then heavily over here in Michigan. The next one, please. So just to say a few words, this is what the curve looks like in Michigan. You can see this is going back up, and it's, you know, it's at about half the height it was at the height of the winter epidemic. This is a real problem, and it is the second worst in the US after New Jersey. These are different scales, by the way, before you have a heart attack over this. They are moving they've had a number of school-based outbreaks, which seem to have their genesis in high school athletics. The schools are going back to virtual, and the hospitals are having increasing pressure on them. In both Michigan and New Jersey, hospital rates are increasing. This is in the race against vaccination. 25% of people living in Michigan have had 1 or more doses of vaccine, and 14% are fully vaccinated. There currently is up to a 11.3% test positivity rate. And Michigan has the second highest level of the B117 variants in the United States. And there's a lot of discussion that this is what is causing this outbreak. It's a race between the variants and the vaccines, and here the variants seem to be winning. Similarly, in New Jersey, where another 20% of the population or so has been vaccinated, with 29.3% having received a single dose and 15.4% fully vaccinated. This is not a lot different than California's, by the way. There's 8.5% test positivity, and New Jersey has a lot of cases of the B117 variant as well, although I haven't heard anyone draw a line between what's going on in kind of the New York metropolitan area and the greater New England area and the B117 variant, although that's something that needs to happen. And New Jersey's put the skids on its reopening plan. So that's what I can tell you about what's going on here. And I'm anxious to hear our third speaker today, who will hopefully elucidate this further. The next one, please. Meanwhile, here in California, we're down to, as I said earlier, about 2,700 cases per day, with under 2,000 yesterday. You can see this really, we're continuing to have declines, although it looks like it's reaching an asymptote. We're below the level of cases in the early fall. We have an effective reproductive number of 0.81, which is good. The test positivity rate is 1.6%. Again, in Michigan, it was 11.3. We currently have 2,500 patients in the hospital, which is down 30% from 2 weeks ago. Here's the hospitalization curve and the ICU curves. ICU capacities come back up to almost normal. We've had our current case rates at about 5.5 per 100,000 per day. And the counties that are most affected with continued transmission are obviously the big counties, Los Angeles, San Diego, Riverside, San Bernardino, but also Sacramento. And San Joaquin is in the next five. So I think we need to pay attention. The new statewide rankings or statewide tiering came out on Tuesday, and you can see Marin and San Francisco and San Mateo and Santa Clara are all in the orange tier, along with this is Yolo County where Davis is, but of the big urban counties, you can see that all of Southern California has come into the red tier. This is Mono that I pointed out. I'm sorry, this is Inyo. This is Mono. Inyo County, Kings, Fresno, Madera, Merced, and San Joaquin, Yuba, and Glen are all remain at the in heightened transmission. And I think this is worrisome with the San Joaquin Valley still having lots and lots of transmission. The next one, please. So we've administered 15 million doses, more than 15.5 million doses. This changes constantly. This is now at a clip of about 400,000 doses administered a day in California. 26% have had one dose, about 12.9% have been fully vaccinated. San Francisco, if we had all the numerators and denominators right, we're at 51% of people having gotten one dose. This is misleading because there's so many healthcare workers that live in San Francisco and got these off the bat. Plus people who work in San Francisco are eligible to be vaccinated but don't show up in the denominator. We're deep into phase 1C. The governor just announced like within the hour, that on April 1st, we're going to move to having, opening this, giving preferential vaccination to people 50 years of age and older. And on April 15th, in lieu of tax day, which has now been moved into May, we're going to open it up to everyone. So we've accelerated ahead of the president's May 1st being widely available here. Here you can see what counties are given. Obviously, the big counties give the most, but San Francisco, Alameda, Santa Clara, Contra Costa are all on this list in the top 10. So we're in pretty good shape. The next one, please. Now there are a couple of letters that came out yesterday, day before yesterday, in the New England Journal, and this gets at the. I mean, we've talked before about the Israeli study by Dagan that looked at vaccine effectiveness in Israel. This doesn't directly calculate vaccine effectiveness, but it does provide a window into what's going on in terms of reinfection of people. This first one on the left is from UC San Diego and UCLA, and it's in healthcare workers. And 15 days or later after the second dose, there have been 7 out of 4,000 cases. This is about 0.15%. And here it's UT Southwestern. It's at 0.05%, 4 out of 8,000. So I think that's pretty encouraging stuff. These are obviously pretty exposed people because they work in hospitals. But we're gonna, we'll have to keep following this forward. But it gives you an idea of how rare these reinfections are, vaccine breakthroughs. The next one, please. And worldwide, Brazil has passed the United States in terms of the greatest number of cases in the past 2 weeks, and you get into the two large European countries, and then India is close behind. The US is falling. India's this is mostly India here in the green. I'm sorry. Yeah, this is mostly, I'm sorry, this is Europe. Anyway, India is falling as well. What's going on is that Europe is increasing, and there's a big outbreak in Europe, not much different from the outbreaks in the United States. and Brazil. And in the European region, you can see this heavy concentration through Poland, Czech Republic, Hungary, Italy, even into Slovenia, and Sweden and Estonia, just so you know, I could count those. And here are the cases in Italy, France, Poland, Turkey, which is not part of the EU. This is from the European CDC, and the Czech Republic. So you can see that there really is continued transmission in Europe, and France, Italy, and Germany of the big European countries have moved for new shutdowns to try and get this under control. And then finally, speaking of under control or not under control, may I have the last slide? We have talked before about Sturgis, South Dakota. Here's the Springs version of Sturgis, South Dakota. This is spring break. This is Sunday, this past Sunday in South Beach in Miami. Okay, 1, 2, good citizens. That's it in terms of masks. So this is a potential to be a large amplifying event. And unfortunately, when I said Michigan has the second highest number of B117 variants isolated in the country, what I didn't tell you was that Florida has the highest number of B117 variants isolated in the country. So this is going to be a really something dicey to keep our eyes on over the next few weeks, and this could easily feed a fourth surge across much of the country. So with that, I'm happy to stop and answer questions. And
great, thank you, George. So let's start with Florida. And you know, there's been a fair number of articles in the last week or two about Florida, about Texas, about states that I think from where we sit, we would say have acted badly. And yet when you look at their case curves, they don't look all that different from California, which on average at least was governed differently. You know, whether people acted differently is a different question. But what do you make of the, you know, I mean, you look at that picture from Florida, you would expect there's going to be something terrible, but the history so far has been, they've done okay, not so much worse than California, as much worse as you might have expected. So how do you explain that?
Well, I think to start with, you know, these people are all going to disperse, so they're not going to get counted into the Florida statistics. So that's going to be that's the first thing. It's like, you know, it's like Sturgis, right? It's like they didn't count in South Dakota statistics; they counted in everybody else's statistics. So I think that's the first thing to point out. There's also I could have showed you pictures from South Padre Island in Texas as well. So that's the first thing. The second thing is the mortality rate in California as a proportion of cases is substantially lower than that in Texas or Florida. And I had to do the calculations. I didn't use San Francisco like you did. I used all of California. But it's, you know, 4,000 fewer deaths in California than Florida, and, you know, 2,500 fewer deaths in California than Texas, or something like that. So it's, you know, the mortality's substantially different. Now people may say, well, 2,500 deaths isn't a big deal. You know, I beg to differ with you. That's a huge big deal. And I think that sort of speaks more to our careful management than anything else. And it's even more pronounced in Northern California. Right. But so, yeah. And, you know, we're just gonna have to see if these earlier releases are going to catch up with them or not.
Yeah. When you look at it, as you sort of analyze these hotspots, it's confusing now because you're trying to, it's sort of variance times vaccine times behavior. Maybe there's some other factor there. When you look at Europe, do you think that France, Germany, Italy are different than the UK? The UK is doing great. Yeah. With tons of variant. Yeah. Is that lockdown, different state of lockdown, or is that vaccination, or both?
It's vaccination. The EU went way out of its way. This is the reports. The EU went way out of its way to take extra time to negotiate a lower price than the US or Britain paid. And that added a couple of months to to delays in vaccine shipments. And so those places are really under vaccinated compared to the UK and compared to the US. In fact, we were trying to figure out about ring vaccination the other day, and it says, oh, Italy's doing ring vaccination. Well, Italy's doing ring vaccination in people over 65. That's all they have vaccine for. So, you know, that kind of speaks to that point. The British, as you know, are put a big, as you know, Bob, well, but a big have big intervals between first and second doses, and they chose to give everybody a single dose of vaccine, and then come back and try and get a second dose into people, and that strategy actually seems to be working pretty well. And then we had the crash and burn with AstraZeneca, which is one of the major vaccines being used on the continent. And so that's created additional problems.
So Harry Hollander asked, when we look at the number of cases, I'm sure it's just somebody wants you to give a talk, George. As we look at the number of cases, those numbers look pretty small. So and you say there's a lot of, I'm sorry, not the number of B117 cases on your list from Michigan and New Jersey. So how much of an underestimate is there in terms of our case counting? And have we been able to calibrate that yet, where we say, all right, we've seen this many B117 cases, it really means there's 10x of that or 20x of that?
Yeah, it's 100x. 100. We're doing about 1%.
Is that right?
Now, is it a random 1%? You're now asking me as an epidemiology about, nah, no way. But it's probably not that crazily off.
Okay. All right. And then Rena Fox asked, are we seeing or will we see a divergence between cases and hospitalizations and deaths? The case numbers are going up in New Jersey and Michigan, but is it less scary than it would have been 3 months ago because a fair number of those people are vaccinated and they won't die?
I think the answer is that a fair number of these people are younger people, and they're unlikely to be dying. But the hospitalizations are going up in both New Jersey and Michigan. So it's not that you get a clean slate. This idea of being able to wall off the elderly and isolate them from everyone else just is never borne out anywhere. So if there's transmission, it'll get to the elderly eventually.
Study you haven't mentioned, when you mentioned the reinfection or the infection rate in people who are vaccinated, I thought you might get to this other study that came out a week ago, I think from Denmark, where they looked at the chances of people getting reinfected.
Yeah.
And, it always feels like it's, one of the reasons we were confident that we might find a vaccine that would work, because reinfection seems so rare. I thought the numbers were sort of wildly high, particularly among people over 55, that prior infection was only 50% protective. How do you interpret that?
Oh, wow. I read the study completely differently. I promise next time you ask me, I'll have that.
Yeah.
It was 0.65% of everybody who got reinfected. I was saying, well, that's not so rare, that they kind of overused that word, but I didn't dig into it that deeply. Sorry.
Okay. No, it's fine. Maybe last question. You mentioned that one of the things that was fueling the outbreaks, I think you said in Jersey, was in the school. You said it was from
Michigan.
Oh, it was Michigan. From athletics. It's become, obviously the schools have been incredibly contentious and people are really passionate about it. But I think the narrative in the last few weeks to months has been the schools are safe, don't worry about the schools. Does your thinking about that change when you see these outbreaks that seem to be based on schools?
Well, I think the thing to say is that that these are high schools. I'm happy to go to the mat on elementary schools, as you know. But high schools are a different creature, and I think that they're, you can vaccinate 16, 17, and 18-year-olds, and there was a question recently about, well, how can we get a high school football team vaccinated and have them volunteer at the vaccination centers? But then they want them to be 18 years old, I guess. So that wasn't such a great idea. But anyway.
But the high schools still are.
It's going to take a while to get there, yeah. But maybe April 15th is the answer now in California.
Yeah, all right, that's good news. I hadn't heard those dates. Okay, George, thank you so much. As always, really interesting and instructive. And let us bring on Annie. There you are. All right, you are on.
All right, if I could pull up my slides, that would be lovely. Well, thanks for asking me on to talk about outpatient COVID therapeutics. I'm not going to cover everything, but I'm going to try and cover some of the areas that have gotten the most interest. So next slide. So, we know that most people who are symptomatic don't end up getting admitted to the hospital. So why do we even need outpatient COVID treatment, which by and large, most people aren't getting, and most of them get better? So I just wanted to help us frame this discussion. The goals of our ideal outpatient treatment. First of all, it's nice to have people be able to feel better. We want to reduce their symptom duration and the intensity. Just because you're not in the hospital doesn't mean you aren't feeling quite poorly at home. We certainly want to have interventions that decrease the risk of developing severe disease and hospitalization. And as we've learned from HIV and hepatitis, if we can diagnose people quickly enough and get them treated, we can break the cycle of infection. So we'd love to see interventions that reduce infectivity and passing it forward and get our R number down. Certainly paying a lot of attention to long-term complications of COVID. We've recognized that these are not limited to those who've only been in the hospital. So while we have very limited data on this, we would like to see interventions that help reduce the likelihood of these long-term, so-called long COVID complications. And in a perfect world, we'd like these to all be orally administered, or at the very least IM, so that we don't have to give people IV medication. Next slide. So I want to start by really the only available outpatient treatment that we currently have, the monoclonal antibodies. And just as a reminder about what these are laboratory-produced antibodies, usually with a single COVID target that's typically the spike protein and typically the receptor binding domain of this spike protein. Right now, they're approved for IV administration, but they are under investigation and have been given subcutaneously or IM, which would be a lot easier. They last for a long time, so that makes a single dose possible to get you effectively out of the woods. And they're generally well tolerated. There's a rare risk of allergic reaction, but in general, these people have done very well with these. There are two major mAb combinations that are approved in the US, and on the left, we've got the Regen-Cov combination from Regeneron, so it's casabirumab and imdevimab, and I'm not going to say that again today because I barely can. And as you can see, they have two different antibodies with non-overlapping targets in the receptor binding domain. And then there's a Lilly combination, which is bamlanivimab and etesevimab, and we'll call that BAM-EDI from now on. And this also targets the receptor binding domain, and there's some overlap that's there. Bamlanivimab has been given by itself as monotherapy, although it does appear that it is more effective to give it along with etesevimab. And so I think that's increasingly where we will see things go. Next slide. So how do these mAbs look for outpatients? So starting with the Regeneron combination, looking at people who are given the mAbs within 3 days of COVID diagnosis, there was an impressive relative risk reduction, so a 70% reduction in hospitalization and death. When you look at the actual numbers, only a small number of people were being hospitalized or dying, so 3 to 4%, and then this decreased to 1 to 1.3%. There was a decrease in symptoms and a decrease in viral load, particularly those who had a high viral load at baseline. And it appears that thus far this is not dose dependent, so you don't need an enormous amount. They started out with pretty large amounts and have been able to come down and possibly even to much lower. Very similar data for BAM-EDI, so also outpatients within 3 days of COVID diagnosis. Very similar number, 70% decrease in hospitalization and death, this time 7 down to 2%. But again, 7% is a small minority of people in the placebo arm who were getting hospitalized. Increased proportion of those with symptom resolution, and I just showed at the bottom, you can see a modest improvement of symptom resolution compared to placebo across the way. And you see a drop in viral load over time as well. And that this combination, as I mentioned, is more effective than giving BAM monotherapy alone. So I think increasingly this is the direction we're going to go in. Next slide. Now, I want to bring up the point, Bob, that you started with and that Adam's going to tell us a whole lot more about, which is the increasing prevalence of variants and our concern about these. And we know that the monoclonal antibodies have shown in some circumstances less efficacy. So BAM monotherapy, and this is in a revised package insert for all 3 of these combinations, basically is recommended not to be used with any of the variants of concern except for the UK variant due to an unacceptably high fold change. And this led to a public health alert from California DPH last week saying basically don't use BAM monotherapy in California where we're seeing, an increasing prevalence of this West Coast variant for which BAM is likely ineffective. Well, what about the combination of BAM-EDI? It looks like there's an increased fold change, so decreased efficacy, but perhaps still retains effect against the West Coast variant and the New York variant, but less so the South Africa and Brazil origin variant. So not recommended there, again, preserving efficacy against the UK variant. I think hearteningly, we're seeing with the Regeneron combination thus far with these variants, there is no change. But I think certainly we've learned that we're going to need to monitor this very carefully for the monoclonals as variants continue to emerge. Next slide. So what's the take home here from my perspective on the monoclonal antibodies? You know, I think there's a modest impact, decreasing viral load, decreased symptoms, a decreased risk of hospitalization. But on the absolute level, you know, this is really not going to be a big game changer. And I think that's reflected in the EUA, which suggests limited use of these therapies. Certainly need to use them early for them to be efficacious within 10 days of symptoms, and they're recommended really in higher risk patients only. This is just a call out box from one of the fact sheets, but you can see that you have to be above a certain age or have risk factors for severe disease in order to qualify to receive these. There are pediatric, you know, adolescent indications that I have not included in this call box. So for the vast majority of people getting outpatient COVID, many of them won't fall into these categories, thus won't qualify. Certainly programmatically, there's challenges to giving IV therapies to a person who is actively infectious with COVID, and I think many programs, including our own, have struggled to figure out how to do this, and thus IM or sub-Q formulations, if effective, would be very interesting. We've seen in the last couple of weeks both data from Lilly and Regeneron that using these monoclonals were effective in preventing infection in high-risk populations, such as those in nursing homes, and showing on the right-hand side some data from BLAZE-1 showing a 72% reduction in infection in nursing home residents who received bamlanivimab monotherapy. But really, how relevant is this if you have a highly vaccinated nursing home population? But nonetheless, it's good to know. And just as a reminder that thus far, there's been no benefit in hospitalized patients to date with 3 monoclonal antibodies that have been studied. So Regeneron, Gilead, and Bree, and this is in the active 3 portfolio. So these are mostly and really only to be used in the outpatient setting right now outside of a clinical trial. Next slide. So what about ivermectin? So this is an anti-helminthic, and there you're seeing strongyloides, which is one of the bugs that it treats. And it has anti-inflammatory activity and then possibly antiviral activity. And I say possibly because the concentration that one needs for ivermectin orally dosed to get to the levels where we've seen in vitro antiviral activity against COVID is going to be very hard to achieve. This has gotten a lot of interest nonetheless, particularly in South America. And we have some data to inform the use. So on the left-hand side, we see a recent study looking at outpatient therapy with ivermectin, and this was published in JAMA. And what they found was that there was a not statistically significant difference in time to symptom resolution, 10 days with ivermectin versus 12 days with placebo. And their conclusion was that ivermectin basically didn't do much for outpatients with mild COVID disease. Well, maybe you need to give it to people who are sicker. And Andrew Hill has a nice preprint that's looking at a meta-analysis of a number of randomized controlled trials that included outpatients and inpatients. And there was a fair amount of heterogeneity in these studies, but he saw intriguingly a 75% mortality reduction combining all of these studies together, some increased viral clearance and time to clinical recovery, decreased time to discharge, but with some really big caveats, which I think he nicely highlights in this article, saying most studies were not peer-reviewed, there's a lot of heterogeneity, and that more definitive trials are going to be needed before ivermectin should be used. Well, what's the downside of using ivermectin? Well, I did mention that oral dosing is unlikely to attain concentrations needed for antiviral activity. And because this is a veterinary anti-helminthic, we've seen, unfortunately, people taking veterinary formulations that are not intended for humans and have had overdoses. And this has led to the FDA having a recent release of saying why you should not yet use ivermectin to treat or prevent COVID-19 to avoid these overdose situations. Next slide, please. So what are my take homes here? You know, currently the NIH and IDSA guidelines do not recommend ivermectin. I think we really need better randomized controlled clinical trial data, and I do not think this is ready for outpatient use. Next slide. Well, what about colchicine? This is an anti-inflammatory that we know better, treating gout. That toe looks awfully painful. and intriguingly after coronary disease. And there was a large study that came out recently called the Corona study with a little over 4,000 patients who were considered higher risk. They were over the age of 40 and had one or more risk factors for severe COVID. And they got 30 days of colchicine versus placebo, but had to be started really quite early, so within 24 hours of COVID diagnosis. They saw a very modest decrease in the primary endpoint of death or hospitalization that was not statistically significant. This became significant when you looked at those who were only PCR positive, so 4.6 versus 6%. I think we'd all agree that that's a pretty small margin there. There was a trend towards benefit in diabetics. There was more diarrhea as you would expect, and unfortunately a trend towards more pulmonary emboli. When you look at the inpatient setting, the recovery study, which we know well at this point, closed the colchicine arm early because there was no benefit to mortality in this group. So what are the take-homes here then? Next slide. I think for use in outpatients, this has not been included in the NIH or the IDSA COVID guidelines, which haven't weighed in. For inpatients, it should not be used. And for outpatients, I think probably the same category. It's a safe drug, but there's a very modest and limited benefit. I don't think this is ready for outpatient use either. Next slide. Okay, fluvoxamine. Well, gosh, why do I even have this medication here? This is an SSRI antidepressant, but it's included because it also has some sigma-1 receptor agonist activity, which can lead to decreased cytokine production and may be an antiviral. And this first was raised with an intriguing study that was published in JAMA. This is a randomized controlled trial of fluvoxamine. I should have said fluvoxamine, that was a misspelling there, versus placebo. These are people with mild COVID within 7 days of symptom onset, and 0 of those who got fluvoxamine deteriorated, while 8.6% did, and this was statistically significant. And this really was a pilot proof of concept. This then led to use of fluvoxamine in an observational post-exposure study. There was a big outbreak at a California racetrack. Over 100 people had COVID. They were all offered fluvoxamine, and 65 of them opted in to take 14 days. And so obviously not randomized. But they saw a pretty, notable signal where none of the people who chose to take fluvoxamine were hospitalized, whereas some of them were in the no therapy arm. And notably, none of them developed symptoms down the road, whereas there were some persistent symptoms in the no therapy arm. This has led to an ongoing study at Washington University called Stop COVID. This is a contactless study of fluvoxamine for people who had symptoms within 6 days. So this means that you can refer them anywhere in the country and they'll FedEx you the medications if your patient or you qualify. This is ongoing. Next slide. So what are the take-homes here for fluvoxamine? Again, not included in the NIH or IDSA COVID guidelines. I think there's an intriguing signal here. I think we're all looking forward to more data from Stop COVID and other clinical trials that are ongoing. I really don't think that this is ready for outpatient clinical use. I think more information is needed. Next slide. So I'm going to talk about vitamin D and then end with just a couple of drugs that are coming down the pipeline so we have time for questions. Boy, lots of observational data showing an association of low vitamin D with COVID. And this is just another recent paper showing that people with lower vitamin D levels were more likely to have a COVID positive test. But as we've learned, association is not causality. I hope I got that right, George. But vitamin D supplementation has failed to prevent or mitigate many other conditions that have been associated with low levels, including tuberculosis. So what do we know about actually giving vitamin D to reduce COVID severity? Well, the data are mixed. There was a pretty impressive study from Spain that showed a decrease in ICU needs in people in an open label randomized trial. Then in a subsequent study from Brazil with a pretty whopping dose of vitamin D, they showed even though the vitamin D levels went up, there was no effect on mortality, ICU, transfer, or length of stay. So unfortunately, I think we're still limited in the data that we would like to inform us here. Importantly, there are many studies ongoing, including the VIVID trial, which is going to look at vitamin D to reduce COVID disease severity as well as to prevent COVID. So we'll really look forward to this because I think we need to put this to rest. Next slide. So the role in prevention is unclear. There's little harm in taking vitamin D as long as you don't take too much, and it might help your bones, but is not recommended for treatment in the NIH guidelines, and it should not be a part of routine treatment given the data that we have. Next slide. So I'm just going to end with a couple of interesting drugs that are in the pipeline. Well, where are all the antivirals? My goodness, this is a viral disease. So a lot of interest in molnupiravir, which is formerly known as EIDD. This is an RNA polymerase inhibitor with a slightly different mechanism of action from remdesivir, which is also a polymerase inhibitor. And in data from CROI last week, we saw that it looked like there was a reduction in viral load, but we're all really looking forward to more clinical data from the phase 2 and 3 studies that are ongoing, both in inpatients and outpatients. Favipiravir had a lot of interest, also an RNA polymerase inhibitor, but again, effective drug levels are difficult to attain with oral dosing, and the data thus far are mixed. I think we really need more data before this is going to be ready for prime time. And then 2 inhaled agents that I think are quite interesting. One is inhaled budesonide, which looks like it may be helpful in terms of reducing symptoms and the time to clinical recovery. So we're thinking about in patients who are just really having a lot of pulmonary symptoms, and it looks like it's quite well tolerated. And then much interest in inhaled interferon beta, which showed a pretty marked effect in an inpatient phase 2 study in the UK, and we're really eagerly awaiting outpatient studies here in the US and in the UK. Next slide. So clearly we need more data. I don't think we have the home runs that we want for our outpatients. And I would encourage people to think about the ACTIV-2 study, which is enrolling all around the United States and can be referred to through this website. And they're looking at IV and IM monoclonal antibodies, IV polyclonal bovine-derived antibodies, which is super interesting, oral camostat, which is a serine protease inhibitor, and inhaled interferon beta, as I mentioned. So I'll go ahead and end there and see if there are time for questions.
Thank you, Annie. That was wonderful. Let me start with a couple. If you get monoclonals, does that influence whether you can get vaccinated and how long you have to wait, and whether the vaccine will work less well?
Yeah. So yes, there is a really nice set of FAQs that the New England Journal puts out about how and when you can get vaccinated, and this is included there. So I would direct people, but the current recommendation is that if you have received monoclonal antibodies for active COVID, that you should not be vaccinated for 90 days because of the concern that this might impair the vaccine efficacy. We have seen people get one vaccine, then get COVID, get monoclonals, and then the question is, well, gosh, what do I do now? They do recommend, and this is addressed there, that you wait, that you continue the vaccine series there and just finish it when you're able to and not be infectious. But for right now, if you're starting the series out, don't get, wait for 90 days to get vaccinated, and hopefully you'll have some coverage there.
Does the fact that you had prior COVID influence whether you should or shouldn't get monoclonals? Now that we're understanding that if you get vaccinated, your response seems to be exuberant with your first dose of the mRNA. If you had prior COVID, is that, if we're beginning to see some reinfections, would that change your thinking about getting monoclonals? You
mean, would you, if you got a monoclonal, are you worried that getting vaccinated might make you have that more robust response? Yeah, or I'm just, if we start seeing people who, with their second infection, would you change your thinking about whether they're eligible or should get get monoclonals for their second response? I think it gets at the broader question of either with vaccines or with prior infection. If you have a breakthrough, are you more likely to have a benign course? And do the data about efficacy that are drawn from people that have had no prior infection, are those relevant? Maybe forget about the prior infection. Maybe the easiest way to think about it is if you have been fully vaccinated, you now get a case of COVID, you're seen as an outpatient, is the probability of you getting sick and dying low enough so that those 70% differences in outcomes in the trials are really not relevant to you anymore? You know, I think that the easy answer is that we don't know, but I think there are cases of people who have gotten quite sick despite it being their second go-round. And initially, I think we were all hoping, oh, it will only be very, very mild and asymptomatic. And that may be the case in a lot of people, although most COVID tends to be mild, except for when it's not, and that's, 20% who get hospitalized. So I think for right now, if you had someone who came in who had a repeat infection, you judge them just as the person right in front of you. And if they meet criteria for monoclonals, or if you're worried that they're sick, you got to treat them in that way as a de novo infection.
Even if you believe the vaccine data that says the chances of you dying is essentially zero. Because if I believe that, I might say the benefit of the monoclonals, was in lowering the probability of a bad outcome, hospitalization or death. It's not that profound a difference, as you point out. If I believe the patient is very unlikely to die because it's an infection after vaccination, it might change my interpretation of that original data.
Yeah, I mean, I hear you, and I think my take on the monoclonals is that on the margin, they're a good intervention for people who are considered at higher risk. It's not for everybody. If you have somebody in front of you who's at higher risk, who's already been vaccinated, if they were 75, if this is grandma, got vaccinated, unfortunately gets infected, the downside of giving monoclonals is pretty low. So it might help them. But I agree with you. I don't think that these are blockbuster, going to change the face of the epidemic. One, because they're hard to give, and two, because most people don't end up going on to have these outcomes.
Okay. One of our viewers asked, can you speak to the cost of monoclonals and insurance coverage of them?
Yeah. So the monoclonals, I don't know at this exact moment in time, but for a while were being provided through the government through a similar mechanism that remdesivir was provided. So had not incurred a charge, although that's a little misleading because it's, well, here's the bag of medicine, but where are you going to get it? So all the logistics about what infusion center are you going to go to, Kaiser had a program in some places and then they stopped. And so where can I go? It's all about the fragmentation of American healthcare, which we're all very familiar with now. I'll say UCSF has done a terrific job of getting that up and going and getting people in and working out all of those logistics. So even when the medicine itself is covered, which my understanding is that it's still under that program, it's really about the logistics of getting a spot to get the IV and a nurse to do so. And that does have to do with insurance coverage at some point.
Got it. Someone asked, what's the current role of convalescent plasma? You weren't talking about inpatient medicines, but in the outpatient world, is convalescent plasma now, its era has passed and been replaced by monoclonals?
I think there are two things with convalescent plasma. One, it's the same trouble of it goes in through a vein, and so for outpatients, figuring out how to do that. There was one really interesting study from Argentina where they looked at elderly patients who were in nursing homes, and if they could identify them early enough, during some of these terrible nursing home outbreaks, and give them convalescent plasma, it looked like it really helped to improve their outcomes and reduce, hospitalization and bad outcomes by something like 50%. So is that truly outpatient? I don't know, but what I'd say is for high-risk settings like nursing homes for high-risk patients, I think there's a role there. But increasingly, I think we've just recognized with convalescent plasma that has to be given so early, or in settings like that where it's a very high-risk outpatient, that you get it to them very quickly.
Great. Maybe final question. One of our viewers asked, any role for monoclonals in immunosuppressed patients that fail to develop anti-S antibody following vaccination being used for prophylaxis?
Yeah, absolutely. So there were some data at CROI last week, which is the HIV conference, looking at monoclonals in people with B-cell deficiencies. So, we make these problems a lot of the time with things like rituximab. And I think that that's an area where we really need to understand better how these monoclonals work. But I know many have been using them, and there was a case series at CROI of people who were effectively treated who were on rituximab with the monoclonals. The tricky piece of that is that right now the EUA says, oh, not for hospitalized patients, although you can work with that a little bit. But I do think that is a population where monoclonals and things like convalescent plasma actually might be quite useful if you think someone just can't mount a response on their own. And I think that plays into the variant issue as well, which is that I know we all have a lot of concerns about people who are severely immunosuppressed. That's one of the groups that can have, viremia that is culture competent for a longer period of time, and might be a good breeding ground for developing variants of concern. I think there's some nice examples of that not only for the patient, we'd like to get their virus under control, but for public health, we'd like to get that virus under control as well.
Great. Thank you, Andy. That's a good segue to talking more about variants. So let us bring on Adam. So hello, Adam. Nice to see you. So Adam Lauring is Associate Professor in the Departments of Internal Medicine, Microbiology, and Immunology, and Ecology and Evolutionary Biology at the University of Michigan. That's a lot more titles than you would have had if you stayed. So that's Good. Adam's research is on RNA virus evolution, and obviously he's found himself in the hot seat over the last year as we've talked about this virus, and he's really stood out as one of the more trusted experts on issues around the virus and particularly variants. As I'm implying, Adam is well known to all of us. Adam was a resident, chief resident here, that did his ID fellowship here at UCSF, but decided he wanted colder weather. So went to Ann Arbor, has done exceptionally well. So thrilled to have him back. He's going to talk to us a little bit about the state of variants and a little bit about Michigan as well.
Great. Well, thanks. It's great to be back with so many of you. See so many names familiar in the participants. Hard to follow Dr. Luetkemeyer. So I'm in Michigan now. Many of you might not know where that is. You take the Bay Bridge east on I-80 and you just keep going and make a left at Toledo and you'll be at my house. So next slide. And these are my disclosures, nothing relevant, I think here. Next slide. So I've kind of put together this talk as a variant consumer's guide because variants are in the news these days, and when I talk to non-medical people, I find people have a hard time sorting them out and what is real and what's concerning and what's not. There's plenty to be concerning about, but there's also what Eric Topol and others described in this New York Times article from Gina Colada as scariants or mutant porn. And this tendency to, describe every variant, like there's a bird, there's another bird. And so, there are things to pay attention to, but there's also a lot out there. So I hope to help you sift through some of this. And so I'm going to talk about terminology, some of the key variants to know about, the implications for monoclonals and vaccines. And then I can't resist a little bit about epidemiology. I hope I'm not stepping on Dr. Rutherford's toes in terms of what's going on in my neck of the woods, which is in the news a lot lately. So next slide. So, and of course, no academic can go without talking about what they do a little bit. And so we've been not collecting stamps or birds in the variants for a while, in that we've been doing broad-based sequencing out of my lab since September, where we've processed 3,700 samples. We have essentially built a pipeline from our clinical micro lab, as well as other testing labs, and get aliquots every week. And we've uploaded about 2,700 genomes. So we have a lot of data on what's been going on over the course of the pandemic, which I'll highlight a little bit here and there. Next slide. So terminology. So there's a lot of talk, but I think it's important to be clear what we're talking about. So mutation is an actual change in the nucleic acid or amino acid sequence. So E484K or N501Y, these are amino acid changes. And then variant, which is the term that's used a lot, or basically just means two sequences that are different. And so a variant can have multiple mutations. And that becomes pretty important when we start teasing out what's actually causing the problem and how to combat it. A lineage, it often is something like a variant, the way it's used. So lineages are basically a variant and its descendants. So B117, a variant, basically we're talking about a lineage. So once there was a virus and it gave rise to all of these viruses that all share many of the characteristics. And then a strain, there was a lot of debate about this early on. It's basically a garbage term these days, I think. So I'll just leave it there. Next slide. So here's the main variants of concern that have been in the newspapers near you. So I'll mainly cover three of them: B117, P1, and B1.351, more commonly known as UK, Brazil, and South African variants. I'm pleased to see California, you have your own variants now, named and famed, B1.427 and B1.429, and I'll acknowledge some great work by my colleague Charles Hsu at UCSF and others on these variants. And then the New York variants B1.526. And so you can see this is a great website, by the way, outbreak.info, where you can really delve into each of these and their characteristics. They have a lot of mutations, some of them, and then some of the mutations overlap, and I'll get into that a bit in a minute. Next slide. So here are the key variants. B117 is kind of the granddaddy in terms of talking about variants, also known as the UK variant. I think as Dr. Luetkemeyer mentioned, there is evidence that this maybe had its origin in an immunocompromised host. And I would say the evidence is pretty good in B117 for that. But the other ones, it's often thrown around, but I'm not sure the evidence is as strong for those. B117, the data is quite good. It's approximately 50% more transmissible, so it spreads easier. The mechanism is still unclear. And then now there's accumulating evidence that it does cause more severe disease. Of course, these are very challenging studies to do to control for all the confounders. But I think the evidence is accumulating and strong. B1.351 is the South African one. It's also seems to be a more rapid spread and transmissible based on the experience in Africa. It has 3 mutations in the spike listed here that appear to be particularly concerning in terms of its ability to escape pre-existing immunity. And that's actually becoming a big issue, I think. And then P1, which is Brazil, also is concerned for immune escape. There's some evidence that there have been a number of reinfections with this variant due to the high initial wave in Manaus in Brazil, and then now a second wave with this. It's also got similar mutations as B1351. And then the California variant, there's this mutation L452R, which appears to affect antigenicity in an important way, which is why it's certainly one to watch. Next slide. So monoclonals. So you heard a little bit from Dr. Luetkemeyer. I can't say the names very well, so I've used some prominent people to illustrate. So there's the Regeneron cocktail or the Trump monoclonals. What he got. These appear to generally retain their activity against many of the variants shown here. And these data are all from the FDA fact sheets on the EUAs. And so, and the mutations are indicated for the variants. And so if you got to go to and you're worried about variants, this appears to be the one to give you now. Bamlanivimab, I couldn't find a famous person who received this. There was talk that Chris Christie received it, but that's not true actually. This one has really, it's got some problems now with the variants. So particularly E484K and L452R appear to make it resistant to this monoclonal. And so now Lilly, who makes this, is rolling out the Rudy Giuliani cocktail. This is what he got, which appears to be better from some of these variants, but you still see there's a full reduction in susceptibility. And so next slide. And so this has driven the government, FDA, and I think CMS to kind of redirect shipments of monoclonals to the various states. So I think California, Arizona, and Nevada aren't getting as much of bamlanivimab anymore. We've been tracking this quite closely with our sequence data, and so we were working with our stewardship team who manages monoclonals at our health system, and we give weekly reports of the frequency of mutations around, and 501Y was up when we had a B117 outbreak, and now we're popping up E484K every now and then, and so they're switching a lot to Regeneron currently. Next slide. Okay, vaccines, and so early on, there were a lot of studies looking at sera, post-vaccination sera, to see how they would do against the variants in cell-based neutralization assays. And there's just scads of papers on this, but these are kind of the most recent high-profile published papers. One looking, and this is with actual virus, so that's also a nice assay. And so it looks like B117 is basically no change in its in vitro correlates of protection with the vaccine. P1 also looks pretty good. B1351, you do take a hit, probably 3 to 8-fold, it looks like in most studies, in terms of the ability of your sera to neutralize. And so the big question is, with these great antibody responses with the vaccines, do you have enough of a buffer to lose 3 to 8-fold in your neutralization? And so next slide. Here's the data on vaccine efficacy and effectiveness as it rolls out. So the Janssen, J&J, and the FDA filing, you can see that it was 72% in the US, a little bit less in Brazil. The Brazilian arm of the study was 68%, where a lot of the viruses had E44K. And then in South Africa, it was 64%. So you did take a hit, and most of the cases were ones that had B1351. Pfizer, in terms of B117, the Siren study with its healthcare workers in the UK, fantastic effectiveness in a time when B117 was circulating. And then Novavax, B117 is also preserved in the UK arm of the study. And then there was a hit in the South African arm of the study with 60% in HIV negative patients, and 93% of the cases were due to the variant. So it appears that B1351, you do take a hit of efficacy. What I tell people is, boy, if we had a flu vaccine that had 60% efficacy every year, I would be ecstatic. So I think, you know, it's worth just keeping that in mind. Okay, next slide. So what we're doing now moving forward is we're merging our considerable sequence data as it comes in with data pulls from the Michigan Vaccine Registry to start seeing, you know, when there is vaccine breakthrough, is it attributable to the variants or not? And so stay tuned. That's kind of where we're going with this research and many others as well. So next slide. So what the heck's going on in Michigan? I can't pick up a newspaper or watch the news without seeing my state highlighted in a not good way. So this is from the COVID tracker at the Atlantic. And Michigan, according to CDC's tracking, the state of Michigan has the second most confirmed cases of B117 after Florida. Good God, Florida, despite having less than half the number of residents. Boy, so we're terrible. We're not great, but we're not that bad. So I think one thing to recognize is, you know, our state lab and others will sequence outbreaks. We've had some Department of Corrections outbreaks. We have tons of cases. And so if you look at total cases, you don't get quite a picture. So overall, 25% of our cases are B117 now, 83% in correctional facilities. In the community, it's 13%. So, you know, use numbers wisely, but still way more than we'd like. Next slide. What we've been seeing is in my area, so we sequence everything from our health system. We had a large B117 outbreak on our university campus in January and February, which we largely controlled. So this is the epidemic curve with non-B117 in gray and B117 in red. And you know, we're suffering by crushing the denominator. So we reduce cases, but you know, B117 just keeps trickling along. And so it's a higher percentage. And what we've been seeing the last couple of weeks is that our hospitalizations are bouncing up, our test positivity is bouncing up. And so is B117 now expanding now that it's higher percentage? And so I don't know. I think B117 is contributing to the epidemiology in our state for sure. And certainly it's contributing. But I think, you know, it's hard to sort out how much is due to that. And I think there's a lot going on in terms of reopening schools, sporting events, bars and restaurants. There's just a lot going on that could be driving the increased cases aside from the variant. And I do worry about variant fatalism, that it's an easy thing to say, oh, the variant. So what can we do about that? But we can control things. It's just the variants make it harder for our non-pharmaceutical interventions. And with that, next slide. I'll just thank you. I don't fancy myself a viral pundit, but I hope my punditry has been useful today. So it's great to be back, and I look forward to hearing some questions.
Great, Adam, thank you. Let me start with here's one thing I just have never understood, and I have not heard anybody explain it in a way that helps me understand it. All right, let's say B117 is roaring through the United States, as it appears to be. It's moving fairly quickly. And then we also have cases of the Brazilian and South African variants that are here. What determines who wins that competition? And do you sort of get taken over by one variant and then another one comes in and sweeps that one aside? Or is it determined by the relative infectiousness of the different variants, or how does this horse race play out over time?
Yeah, I think it's a great question. I mean, it's one of those really fascinating scientific questions, right? That my guess, and again, I'm putting on my viral pundit hat, which, like most pundits, I'm wrong a lot, is that so these viruses are competing with each other, right? And so I think B117 will win because the advantage in terms of spread, its transmissibility is significant, and so it's going to find more hosts quicker.
Compared to the native, or compared to even than South African and Brazilian?
Both.
It's more transmissible than those other variants.
Yeah, I mean, we don't know for the other variants. The data is not as good. So it might be that it's not that different. But my sense is that, that the B117, is more so than even the other variants. And of course, it has a head start, right? It's the first one past the gate. And so it's going to take over quicker. But then the other thing is, well, it's not, maybe these other variants are going to have a little bit of an advantage on their own right in terms of, as the population becomes more immune, that they could then outcompete B117 in that arena. So a lot is going to depend on the complexities of, how immunity develops in our population over time.
Yeah, I assume there's sort of mathematical modeler types who can
Yeah.
tell you that basically
Yeah.
one of them runs faster, but once vaccination becomes more prevalent, then the advantage of being able to escape vaccine takes over the fact that it runs a little slower.
Right. And of course, there's, kind of second order effects too, right? Once you reduce, enough infections, do you start having, does the transmission advantage become lower? Yes. Short answer is a modeler can spend a lot of time and provide and certainly provide some insights, I think, for sure.
And get a few grants. So when you get asked, I know you've been doing a fair amount of media these days, the sort of optimistic, pessimistic, are we back to normalish by summer question? Everybody's answer is vaccine versus variants. You study the variants. What's your answer to that question?
Gosh, I think again, I've been overly optimistic and wrong throughout the pandemic, so take that with a grain of salt. My sense is that we're putting too much thought into vaccines, really, in terms of the variants. I think, what concerns me is, the United Kingdom did not control B117 by vaccination. They controlled it with a lockdown and vaccination. And so I mean, it does worry me how we're kind of approaching this and, thinking about it as a vaccination problem. That said, I am optimistic that I think summer, if we get enough vaccinated people and we can kind of get things under control, that, we'll be in a much better place. But, I must say the last couple of weeks here have really kind of, pushed me to the pessimistic side, because I thought we were already heading closer to that direction, at least in my neck of the woods.
Yeah, I finished listening to your Michigan discussion, still a little bit unsure, which may be an accurate reflection of where you are. But is your sense that it's being driven by a disproportionate amount of the variants, or do you think you're looking more carefully and you really don't have that much more variance than everybody else if everybody was looking as carefully as you are? And if that's right, then what is it? What's going on there?
Yeah, I think we got variance. It's not quite the same as, some of the numbers suggest, but it's more than you need. And I do think that it's, it's certainly one of the drivers. But I think that the same drivers are happening in many states. And, there's, certain things I think in Michigan that might be leading to the cases going up. And I also think that there's of course, we've seen in the pandemic that there's a lot of stochasticity in this whole thing, right? Like, why one state will all of a sudden have an outbreak, you're not doing anything different from another state, right? There's a certain amount of luck. And then, I'm shaped in my thinking a lot. It's like we had a big campus outbreak in January and February. And at the same time, that's when the variants arrived. But when we look at the data, boy, we only had like 40 or 50 cases that were B117 and like 1,000 that were non-B117. And so it just highlights how challenging it is to determine what's determining your case numbers and your hospitalizations. But without a doubt, the variant's contributing. I just think it's hard to tease out, and we might be overemphasizing the variants in some cases.
What's going on the ground there in terms, Michigan was one of the liberate fill in the blank states. I assume it was getting open as things were getting better. Is it getting closed again, or is the politics such that people are saying we've got to stay open and, no matter the numbers?
Yeah. Well, I can tell you, I'm in a little bit of a bubble here in an academic, university within the state. I think, I haven't seen any big policy changes coming. Doesn't mean they're not going to come. But it's a challenging political landscape. I mean, I think without getting too much into politics, I mean, your governor might get recalled. Our governor, she was at risk of being kidnapped.
Yes.
So it's just a different, landscape.
But forgetting about what one thinks about the politics, are the rules changing? Or are they beginning to lock? Are they closing?
No, I haven't. No. I mean, in fact, at least our school district is, starting to go back to, hybrid learning. I haven't heard of, things, going back in terms of, capacity in restaurants and things like that. But that said, I would not be surprised if things, start changing, that, we would, ratchet back in our state, just kind of knowing how things are playing out and how the politics are likely to play out.
Yes, my older son went to school there, and heard the saying, Ann Arbor is 5 square miles surrounded by reality. So
yeah,
it is something of a bubble. What's your take on Brazil? I find Brazil the most confusing thing. The media reports are hellish. I mean, it makes it look apocalyptic. Tons of reinfections, numbers that should be herd immunity, but don't seem to be. I can't tell how much of that is real or hyperbolic, and what the variant's doing down there. Do you have a sense?
You and me both. I don't. And I must admittedly, I haven't delved into the, really poured over the papers, that describe Brazil. I'm interested in what Dr. Rutherford thinks, because I just, it's confusing because, the data can be suggestive, but then, sorting out reinfections and how much of reinfection is due to the variant versus just that's what's around. Yeah. It's hard, but certainly it's concerning enough, even if the numbers are off, right? And so I think that is that's what I take from it. But it's confusing for me, for sure, at least to me.
One last Michigan question. Are you seeing a disconnect between cases and hospitalizations there? I don't know if you know the hospital's data, but one wonders, are we seeing more cases, but they're in more of them are in vaccinated people, and the cases and the bad stuff are now going to get disconnected compared to earlier?
Yeah, we haven't seen that. I mean, I think what people have remarked, and this is pseudo anecdote, right? So it's limited numbers of people, is that some of our common colleagues, in the hospital service were like, boy, the patients look different, right? It's, maybe they're younger. And looking at epidemiology data, it seems like some people are seeing that in other places, right? As, because we prioritize older people vaccinated first. And so, maybe, we're going to shift the age distribution, and maybe it's also where transmission is happening, right. Socially. So, but in terms of, I haven't seen anything strong in terms of, severity or spectrum of disease, recently, but it's something people are wondering about. Yeah. But the numbers just aren't there.
Okay. Maybe last question, this is one of our viewers. Is our current obsession with variants simply a matter of looking for our lost keys under the street light because there's more light there? Or is there something unique about SARS-CoV-2 that makes them legitimately concerning, aside from the fact that we're becoming more aware of them?
Yeah, so yes and yes. I think there is a certain element of you're looking and you're finding, and a lot of catch up in genomic surveillance in the US. We're still not the United Kingdom in terms of how to do this. So we are finding things, and people are things are getting described, and yeah, some is concerning, some's not. And of course, we often forget, this is what happens with influenza every year. There's surveillance for variants, you relate that to vaccines, you update the vaccine, this is bread and butter. Mm-hmm. And so I think the concerning part about the variants with SARS-CoV-2 is, as people have noted, it's we're seeing them, they're arising a lot now because for several months we've had an uncontrolled, spread of the virus in most of the world.
Yeah.
And so that gives the virus a lot of opportunities to try out new solutions. And
Yeah.
that's what leads to the variants. And so I think that's the difference.
Yeah, I guess I'd never paid attention much to to me, the influenza story was, okay, the virus does some shape shifting, and to make a vaccine that works, we've got to shape shift for that. Never heard or thought that the new version is more infectious, more fatal, more likely to escape more likely to escape the vaccine. That's the idea of having to create a new vaccine. But is it true that forever in influenza, these new variants each year actually can be more infectious or more serious?
Well, I think, more infectious, it's of course harder to tease out with influenza, right? Because, more infectious is so intertwined with your immunity from prior infection or a vaccination. So that's where SARS-CoV-2, you've had essentially a naive population. And then similar probably for severity, it's been very hard to tease out. And even with SARS-CoV-2, the severity thing is probably the thorniest problem, right? Because think of all the things that can affect severity, right? In terms of the host and kind of the population level factors. And so I think, the UK, which has had phenomenal amount of data, both sequence data and, through Public Health England, if you have all that data, you can start teasing out some of these things, but I think it's really hard for any other place to really do a good job with that, even in SARS-CoV-2, much less with flu.
Yeah, great. Adam, great to see you. Glad things have gone well for you. We miss you, and keep up the great work.
All right, thank you.
All right, thanks. All right, we'll sign off for this week. And here's our wonderful production team. Next week we'll be back with a non-COVID themed grand rounds, and back to another COVID session a week after that, and keep doing that as long as COVID stays real and keeps changing and stays interesting, and it still is, and lots of new stuff. So thanks for joining us, and we will see you back here again next week.